All right, so we'll get started. If any of you folks have any questions, please feel free to leave those as chats. And once I'm done with the presentation, we will go through that and hopefully you find the answers you have been looking for. So today's presentation is about how AI and FHIR are finally solving prior authorization demo, and we'll also see some strategic insights onto that. So, quick introduction, I am Arbaz Siddiqui. I am the Senior Accounts Manager for Cap Minds, and I oversee health IT projects, especially in the case of interoperability and other integration related projects. So today's agenda is very simple. So all of you, I'm assuming, are coming from the Medicare mandates are reshaping healthcare. Then we will have a quick introduction to FHIR. Then we will see what is the role of AI in prior authorization. Then we will see some sample AI plus FHIR architecture. And then we will see a live demonstration and a real world impact. So moving on to that. So, first of all, let me give you a brush up on what is prior authorization. So, prior authorization is basically the process of receiving approval for a medically necessity service to see if the patient is covered. When we have prior authorization, it reduces denials. It also makes sure that you're not doing an expensive surgery before checking whether the patient is approved for it or not. So we will see what is the scale of this particular problem. So we have about 300 million plus prior authorization requests which are processed annually in US, and average physician time spent on prior authorization per week based on a survey is around 13 hours, and around 93% of physicians and clinicians report prior authorization related care delays, and around 82% of physicians abandon treatment due to PA because it's a very frustrating process, as we'll get into it. And for each manual PA processing transaction, each clinic or organization is spending about 11 to $14, and around 13 billion plus dollars are annually spent just on admin costs to make sure that the PAs are being run properly. So now that we have the problem established, now let's look at what is the human cost. So because we are in the medical industry, the topmost priority is obviously patient care and making sure that the patients are getting the best care and they are cured. So first case we will look at it's a real patient story. Because of PA, they might have had some cancer treatment. So, a newly diagnosed breast cancer patient waits around 11 days for prior authorization approval for their chemotherapy, which is obviously very bad. The oncologist office spends around 6 hours on phone calls and faxes and peer to peer reviews to make sure that we get the proper prior authorization for this particular patient. Then we have case two, which is a mental health patient. A psychiatrist office abandons a prior authorization for a mood stabilizer after three denials, so which was very necessary for the patient. And the patient's therapy plan is now disrupted, and the case is documented as a PA-related care gap. Now we have case number three, back. So a patient discharged after orthopedic surgery cannot begin physical therapy because the PA was not initiated before discharge. Now hospital readmission follows just 9 days later. So these are just some of the cases, obviously coming from the healthcare industry. You might already be aware of thousands of these stories. Obviously the main case that we are making here is that the time spent on PA right now is not reasonable. And that's what we are planning to solve here. When the time spent is reduced from, let's say, 11 to 14 days to 2 3 days, then we can say that, okay, right now we are at a very efficient timeline here. Now moving to the next agenda. So now we understand what the current system is. Now let's understand why the current system is currently broken. So we have 8 painful steps currently for prior authorization. The first step obviously is the physician identifying the treatment needed. So then we enter the order in the EHR, then staff manually checks coverage, then they check each portal. Obviously by coverage, we mean eligibility and, my apologies, verification for the patient's coverage. Then the staff logs into the payer portal. Each payer has a different portal. Then the PA form is filled out manually, sometimes on paper or PDF as well. Then the PA is submitted via fax or portal. There is no standardized format. Each payer has their own format to receive PAs. Now we wait for payer response. Its average is between 3 to 7 business days. This is on a good margin. We have seen cases where the clinics have to wait even 2 weeks or 3 weeks. Then the payer requests more info. Then we are back to, again, the staff needs to gather the medically necessity information. Then we need to send it across. Then if there is a denial issued, the appeal process begins. Another 2 to 3 weeks gone into that. And then the patient is waiting for their appointment, and then the provider also loses out on their revenue. Then once this is done, then we have a peer-to-peer review scheduled. Then the physician time again gets wasted into that. Now moving forward. So now we understand why the current system is broken. Now let's look at what are the regulatory shifts. Obviously, CMS understands that this is a big issue. Now there have been some mandates that have come in to make sure that these issues get resolved as well. So as we all know, in 2021, CMS had their interoperability and patient access rule. So which means that payers must expose their patient access API via FHIR R4. So, 2021 CMS mandates that all the patient data should be accessible. Then January 1, where we are right now, 2026, the CMS prior authorization rule. This is a landmark shift in the mandate, so which means that payers must implement FHIR-based PA APIs. So whatever the old system that they were using has to change, and it has to be a FHIR-based PA or prior authorization APIs, which allows fast access to get the prior authorization done. Now looking ahead, 2027, we have provider access API, so real-time patient data sharing between providers. Then we have payer-to-payer APIs, so continuity of care between different payers and all of that. So that's in the future. Now let's look at FHIR as a solution, or first let's look at what this particular shift in the mandate means for all the stakeholders. So we have three main stakeholders here. One is obviously the main affected party, which is the health plans or payers. So they have to build or buy a prior authorization based API infrastructure so that they can receive FHIR based requests. And that means that they have to reduce decision, have to expose the denial reasoning in the structured data. Then non-compliance, then if they go that route, that becomes a CMS audit and penalties, obviously. Now, for providers, health systems like EHRs, we have EHR systems must integrate FHIR-based prior authorization APIs, and then the workflow needs to be redesigned. Obviously, for that, the prior authorization triggers at the point of order entry. The staff needs to get retrained on this, and they have to understand this digital first prior authorization process. Then we have an opportunity to reduce administrative burden here. Now for vendors, health IT, such as our company here, we have to So, just to brush up a little bit, FHIR is basically fast healthcare interoperability resources. So, this is basically a language in which multiple healthcare systems can speak with each other. So, we have to understand how FHIR functions. So, the first part of FHIR is obviously its resources. Every piece of the clinical data, it can be a patient, practitioner, the patient's demographics, their clinical data, all of that becomes resources in FHIR. Then we have APIs, the systems exchanging resources via REST APIs, the same technology powering Amazon, Google, and every modern service that connects with different systems. Then we have profiles and validation. So the domain specific rules shape how resources are structured. So FHIR has, is specifically for healthcare. FHIR has, profiles and validation to make sure that the healthcare data remains secure and structured. So moving forward, now, to understand what are the key FHIR resources, which we covered right now in prior authorization, we have to understand, how a prior authorization workflow can be powered by a FHIR. So obviously the first resource is the patient, which contains their demographics and identifiers for that particular patient. Then we have their coverage, their insurance plan, member ID, their group number verification. Then we have claim and claim response. So PA request submission and then payer responses. Then we have condition, obviously the diagnoses, and which is linked to the particular prior authorization request. Then we have medication requests. So in case of medication prior authorization, we have specific drug which is being requested and the dosage details. All of these things will go in a FHIR bundle to the to the payer, and then the payer will respond. Then we have a service request. What is the procedure or service being requested by the provider? Then we have document reference, their clinical notes, imaging reports attached to the prior auth, and all of that. Then we have task, the real-time status of that particular FHIR request. Then we have communication request, peer-to-peer peer review, whether it's required or not, all of these details. So with all of these resources, in FHIR, we can have all of these bundled in a FHIR request and send it to the payer. That's what the future holds. Now moving forward. Now, what is the Vinci prior authorization support workflow? Let's take a look at that. So we have six workflow items here. So the first is the EHR or provider prior authorization support workflow, where the order gets entered. So the particular procedure, the prior authorization request, the drug request, the clinical documentation, all of that. Then we have the FHIR claim bundle, as we were talking about. FHIR bundles all of these details, and then using their intermediary API, which is the FHIR prior auth API, the, it validates, adjudicates, and then routes the request to the particular pair. Then we have the response bundle, which the pair uses, whether it's approved, denied, pending, or it's there is a structured result code. Then the EHR displays the result. So this is basically the main workflow. Then we have real-time status tracking. Obviously, once the prior auth request has been received by the payer, then the payer approves or denies it, then sends it back. All of that gets tracked in the real-time status. Then in the Da Vinci prior authorization systems workflow, what are the key standards that we have here? We have HL7 Da Vinci Pass IG that we are looking at. Then we have CDEX, Smart App Launch, US Core Profile. So these are basically standards used for this particular workflow. Any one of these can provide the same workflow that we are looking at. Now moving forward. Now, what role will AI play in the prior authorization workflow? How does adding AI, will it affect the workflow positively, negatively? Let's look at that. So let's look at what FHIR is able to solve first, then we'll look at what it's not able to solve. So FHIR solves obviously the data standardization, the real-time exchange, structured denial reasons, and status visibility. Now, it does not solve determining if a PA is even required. So AI can probably run through the clinical documents and see beforehand whether a prior authorization request is necessary or not. Then it can also look at use cases from previous data, and it can predict whether the approval, what is the likelihood or what is the percentage that we can expect that the PA gets approved or not. Then it can auto-populate the clinical justification from the EHR notes, which obviously the insurance payers come back and ask for it anyways. Then it also it can identify from the submission what are the missing documentation or not. Then it can also draft appeals for denied requests. It can learn which payer specific criteria maximizes approval rates. So this is what adding AI can do, but let's see how it will happen. So let's look at a particular use case, AI-based use case in the prior authorization lifecycle. So just to summarize things, FHIR will solve the language problem, but AI will solve the intelligence problem here. So in order entry, AI can determine, whether the prior auth is required or not. Pre-submission, it can, document or auto-populate all the EHR notes for the clinical documentation. It can run eligibility check of coverage verification and the benefits of that particular patient. It can see the clinical criteria, what is the patient data required for payer specific guidelines. Then it will check the completeness of the document, flag anything missing there. Submission automatically generates the FHIR compliant PA bundle. Then it can monitor the status, predictive modeling on approval likelihood, and all of that. Then we have denial management. It will automatically generate appeal letters based on the denials. Analytics identifies denial patterns to optimize future submissions. So this is overall how we can use AI in the prior authorization lifecycle. So it's becomes a very interesting use case study once we get deeper into that. Now we have natural language processing or NLP, turning the clinical notes into structured evidence required for the prior authorization. So what is the challenge? 80% of the clinical data, it lives in unstructured free text. Obviously, the provided notes are not structured. So what NLP can do is, it can ingest raw clinical data, automatically extract the diagnoses, medications, lab values, prior treatments, and then map them into the payer specific criteria in seconds. So, this is just, 5 items how that will happen. Let's look into that in detail. As a first step, it will ingest the raw clinical notes from the EHR. Then, as a second step, it will extract clinical concepts, diagnosis, medical medicines, lab values, CPT, ICD codes. Then it will map it to the pair specific medical policy or criteria. Let's say UHC has a criteria, BCBS has a criteria. Then it will populate the PA form with the pre-filled structured clinical evidence and then flag gaps where the documentation is insufficient. Now let's look at how everything will work together. This is a AI plus FHIR architecture sample which we have built. So we have on the one hand a provider ecosystem, which is basically their Epic, Cerner, their FHIR apps, all of their provider portals and everything. On the right hand side, we have the payer ecosystem, which is their endpoint where they receive all the PA requests, eligibility requests, all of that. Then we have in the bit middle, which is our middleware, which will process all of this data between these two systems. So we have the NLP engine, which will work on the clinical documentation. Then we have the rules engine for the pair criteria. Then we have the prediction model, which is the approval likelihood. Then we have the appeals generator. So this is based on our research so far, and this is how we can make sure that our time, gets reduced from 14 days to 2 days, 3 days, or whatever, right? So let's look at some performance metrics as I was speaking now. So, average prior auth turnaround time is between 4.2 days. After AI plus FHIR, the submission time gets reduced to 38 minutes. If the endpoints and everything is working properly, then first pass approval rate goes from 61% to 89 percent. Obviously, there might be still some denials based on medically necessity documentation or the PA not required and all of that. Then staff time per PA request. This is where the real impact happens, from 23 minutes to 3 minutes now. PA related denial rate from 22% to 7%. Appeal success rate from 41% to 74%. The satisfaction of the providers goes from 34% to 81%. Then cost per PA transaction also reduces from around $14 to $2.4. So this is what we plan on achieving in the near future and moving forward. Obviously, the main goal of all of this is to see what changes it will bring on a human level, because a patient's care is at stake here. So for the patient outcomes, we can see a 19% reduction in treatment abandonment. So a treatment which is really necessary doesn't get abandoned because of a lack of PA. There is a 27% reduction in medication non-adherence. So real-time approvals at the point of prescribing, they make sure that patient keep taking their medication, reducing complications and hospitalization. Then we have fewer 30-day hospital readmissions because of the PA wait time, so eliminating PA-related care gaps and high-risk patient cohorts measurably reduces the costly hospital readmissions. Then we have physician satisfaction and reduced burnout, meaning that physicians can spend more time on patient care rather than working on these irrelevant admin tasks. So this was the presentation. Hope you guys looked at this and found some valuable information. Now I'll look if you guys have any questions, and then obviously you guys can always reach out to me to info@capminds.com, and if you want to talk, we can go ahead and we can talk as well.